Welcome to Palliative Care Explained, a channel aimed at answering your questions about palliative care. My name is Dr. Jonathan Wong, and I am a palliative care doctor based out of Winnipeg, Canada. In this two-part video series, we will be discussing the 5 W's of palliative care: the what, who, when, where, and why. In part 1, we will talk about the first W, what is palliative care? And in part 2, we will talk about the remaining W's. Firstly, please see the introductory video of this channel for information about me, why I am making these videos, my declaration that I do not have any conflicts of interest or financial sponsors, and my medical legal disclaimer statements. Let's first talk about what palliative care is. In broad strokes, palliative care describes an approach to care that looks beyond one's illness and shifts the priority towards improving a patient's quality of life. It doesn't mean that your healthcare team is giving up on you, ignoring your illness, or not looking for ways to extend your life. We're not giving up. Rather, your healthcare team is focusing on you as a whole person and looking at all the parts that make up that person, instead of solely focusing on your illness. Now, despite all the advances in modern medicine, an illness can still progress to become incurable or uncontrollable. And it is at this point that we really start to rethink about what the end goal should be. Is that end goal still life prolongation at all costs? Or are there now competing priorities that were once previously pushed aside? It is at this turning point that the idea of palliative care or a palliative approach to care is typically brought up. So what does this palliative approach include? As mentioned earlier, the goal of palliative care is to improve a patient's quality of life, and we try to achieve that by addressing both the physical and the non-physical aspects of living with a serious illness. Physical aspects include assessing and treating symptoms such as pain, nausea, or shortness of breath, for example. Here, we often use medicines and up-to-date technology as well as non-medicine strategies to help patients physically feel better, or as good as their bodies will let them. If appropriate, this can include testing for medical conditions that might be reversible. For example, getting a chest x-ray in someone who is short of breath to investigate for a pneumonia. But the difference now is that the goal should no longer exclusively be life prolongation. Rather, now we are paying more attention to what is tolerable for the patient, what will more likely make them feel better, and more closely evaluating whether a medication or a surgery is truly in the patient's best interest. And most importantly, does the patient actually wish to undergo a particular type of treatment? What are their preferences? At this shifting point, some patients feel that their healthcare team is abandoning them or giving up. And I really want to emphasize this next point. Palliative care is not a form of giving up or ignoring medical issues or pushing things under the rug. Instead, palliative care puts effort into making patients live better by re-examining their goals and their expectations. We have just discussed some of the physical aspects. The other big category of what palliative care does is addressing the non-physical aspects of living with a serious illness. This includes psychological and emotional factors, social and community factors, spiritual and religious factors, and those two are not always the same thing, exploring a patient's hopes and fears, and helping them cope with the feelings of loss and grief. Palliative care as a field and branch of medicine has evolved so much in the past several decades. palliative care has historically been called comfort care or end-of-life care. Now, this is still true, and end-of-life care remains a large component of the modern palliative care scope. But there's more to it than just that. And ideally, it should not be that abrupt of a transition. Palliative care is now being included much earlier in the course of an illness now, especially in the treatment of cancer. And this has resulted in improved patient experiences and outcomes. In an ideal world, both a curative approach and a palliative approach can coexist together, and both teams can cooperate together. In earlier phases of the illness, the team whose goal is to prolong life takes the leading role. But as the illness progresses and as the patient's needs changes, the palliative team can then start to take a more active role. But both teams still work together. I also wish to convey to you that palliative care is not just for those at end of life. Rather, it is for any patient with a life-threatening illness or incurable illness, even in the earlier stages. It doesn't always mean death is near or imminent. So to summarize part one, what is palliative care? Palliative care is a shift toward paying more attention to and reevaluating what is truly important for the patient in the context of a life-threatening illness, and not just solely prioritizing prolongation of life. The goal is now to make patients symptomatically feel as good as they can and experience, hopefully, a better quality of life. I hope to see you for part 2 of this video topic. Thank you for watching this video.